Thank you, Ross. As Ross said, I am a DO, and I have an integrative wellness clinic in University Place, Washington, where we provide holistic model of care to our patients. We treat mental health diagnoses, chronic pain, and we provide overall wellness care. I've been practicing for 20 years, and in that time, I have identified that genetic testing has really transformed the way I practice medicine. And I want to share that with you so that you are really able to see the importance of it. But first, I want you to close your eyes. And now I want you to raise your hand and keep it up if you or a friend, a loved one, coworker, acquaintance has been affected by depression. How about anxiety, bipolar disorder, panic, PTSD, ADD? Now keep your hand up and I want you to open your eyes. I want you to look around the room. It is really profound, the effect that mental health has had on the community, especially in the last 3 years. Finding the correct medication is essential. And finding it the first time we prescribe is really difficult. Did you know that 40% of prescriptions fail to achieve their desired outcome in patients? And one of the reasons is because 50% of patients have genetic alterations that can affect the rate of drug metabolism. Now I want you to imagine having a test that can identify and individualize mental health medications for a patient. And that's essentially what IDgenetix can do. Medication selection can be really, really challenging. I want you to look around the room. And if we were all diagnosed with major depressive disorder, half of us would have an inadequate response to the first medication that we were put on. And the likeliness of side effects and of discontinuing our medication would go up to 40% with the fourth medication. I mean, imagine being put on the first medicine and having it not work. The trust that you have with a patient just goes down. And then being tried on another and another and another. 3 out of 4 of us, so look around, 3 out of 4 of us wouldn't achieve remission if we used the standard of care for treating major depressive disorder. So I'm not going to tell any of you anything you don't already know or anything that you have not been experiencing, but our mental health in this current healthcare environment is completely broken. It leaves 50% of patients who are treating healthcare completely out in the cold. And they often are seeking care by primary care. And like I said, the medications that they try, there are medication failures, and greater than 50% have low remission rates. We have this current model that we've all been trained in, and it's that trial and error model where we prescribe medications which are based on side effect profile, our clinical judgment, our past experiences as providers. And unfortunately, that model is not serving us well, or rather, it's not serving our patients well. I mean, look at these numbers. They're truly that 50% of patients with poor remission rates, or the 3 out of 4 that don't have a response. I think first we need to look at why it is so difficult to predict medication response. Again, I want you to look around the room. Half of you take more than one medication. It's 50% of people take 4 medications. That puts us at huge risk for drug-drug interactions. But then I'm going to give you an astounding number. 97% of patients carry a genetic variant that affects drug metabolism. So that's a gene-drug interaction. So now we're compounding this drug-drug interaction and gene-drug interaction. These patients are incredibly complex. We are treating patients that are more complex now than we've ever treated before. I remember I was in medical school and I was started on an antidepressant. And, you know, when you're depressed, it is harder to do things, anything, everything is hard. And I can remember I was started on my first antidepressant and it didn't work, or I had side effects. And I was then started on a second and that didn't work, and then a third. And I want you to imagine being in medical school and trying to juggle all of your classes, all of your schoolwork, and then the doctor's appointments, in addition to feeling depressed and the side effects of the meds. And I got caught in that cycle of prescriptions. And so finally, I just canceled my follow-up appointments. Yes, I was one of those. The bottom line is our mental health system is broken. And our patients are more complex now than ever. And so predicting medications is really difficult. And if we have a test like IDgenetix that will help us predict the correct medication the first line and help us improve our chances of response and remission, we sure should be using it. It's almost negligent not to. All of us treat major depression. And I know all of you are very familiar with the complexity of diagnosing and the components that all are part of it, right? The comorbidities, the environment that contributes, the social and behavioral issues. But how familiar are you with the enzymes that contribute to breaking down medications, or the transporters that may be part of it, or the activators? Those things are just as important when we are trying to decide on medication. And at this point, these largely have not been considered when deciding on medications. Before we go into the specifics of how IDgenetix will really help you in the clinical practice, let's do a quick refresher. Pharmacogenetics, very simply put, is using genetics to better understand medication metabolism and to mitigate risk. If we have any hope of personalizing treatment, we need to use pharmacogenetics. And there are 2 pharmacogenetic areas. One is pharmacodynamics, and that is what a drug does to the body, receptors, ion channels, signaling pathways. And then the other is pharmacokinetics, and that's what the body does to the drug. This is looking at our absorption, distribution, elimination, and metabolism. It's looking at those cytochrome P450 enzymes, the ones we learned about in school. So let's look at phenotypes. If you remember in genetics, phenotypes are the observable trait. When we talk about phenotypes in terms of pharmacokinetics, that is the metabolizer status. So if we look at the metabolizing in terms of a poor metabolizer, it means that that person is not metabolizing medications effectively. So you may need to decrease that dose requirement because their serum levels of the medication would be going up too much because they're not metabolizing well. An intermediate metabolizer also is not metabolizing very well, therefore their serum levels of the medication would go too high. An extensive metabolizer is one that metabolizes at a standard rate when you compare them to the average population. An ultra-rapid metabolizer is one that metabolizes medications very rapidly, and therefore their dose would need to be adjusted up because they are rapidly metabolizing their medication. Everyone has their own unique genetic profile, and different people metabolize medications differently. So I want to take this example so you can see clinically how this works. If you have 10 people that come into your practice and they're all diagnosed with major depressive disorder, often as clinicians, we look at a diagnosis and we will treat them according to the standard of care. It's how we were trained. And on the surface, that makes a lot of sense. But now, with our new understanding of the different phenotypes, it may make more sense that treating everyone the same, with the same dose right out the gate, is unlikely to give us the outcome that we want for our patients. So using this phenotypic information, we may be able to identify those who will metabolize medications very quickly, those ultra-rapid metabolizers, or those that are expected, or those that have poor relief from symptoms, those ones that are the poor metabolizers. So let's go to this example. This is an example that I think probably all of you have seen. Our patients come in with major depression. We start them on Celexa at 20 milligrams, which is the usual start dose. And we continue to monitor them through with our PHQ-9, and we adjust their medication based on our progress. And not all of them respond to that 20 milligrams like we had hoped. Here's why. Phenotypically, they are not all the same, right? We find that one of them is an ultra-rapid metabolizer, is metabolizing that 20 milligrams much faster, so therefore needs to be moved up to 40. There's 8 of them that do well on that 20 milligrams because 5 of them are extensive metabolizers. 3 of them are intermediate metabolizers, which may metabolize a little lower than the extensive metabolizers, but not enough that they need an adjustment on their medication. And then 1 of them is a poor metabolizer, and therefore the serum level raises and needs to be put down to 10 because either they're having side effects or are not feeling quite right, and so the dose needs to be adjusted down. This really shows how the phenotypic metabolism status makes a difference in a medication that you all are very familiar with, and how important it is for us to know that right out the gate, starting with a one dose fits all is not necessarily going to be the dose that we need or the approach that we should be using. I'd like you to meet this case study. She's a 44-year-old female with 20+ year history of chronic resistant depression. Of note, she also has rheumatoid arthritis, migraine headaches, Hashimoto's thyroiditis. And over her history, she's tried Zoloft, Celexa, and Lexapro. Zoloft caused nausea. Celexa also caused some nausea, and Lexapro caused an increase in her headaches. She's attempted cognitive behavioral therapy with some success, but not response or remission. She reports feeling down and depressed most days, no suicidal ideation, significant anhedonia and lack of motivation, continues to work, but does little outside of work. Her concentration and sleep are greatly affected, thus her productivity suffers. And when asking her significant other, he also reports that she demonstrates depressed mood. She does see her PCP, who very intelligently decides to do an IDgenetix test. Her PHQ-9 is a 17. So when she goes to her PCP, she has this IDgenetix test done. And what I can tell you is, although the science is very complex, this test is very simple. It's a buccal test, which is a swab done right in the cheek. Takes about 40 seconds to collect, and then it's sent off. You can actually do it in the office, or you can actually do it by mail. I like to do it in the office because I like to sit with the patient, explain things, do my consult with them. There is a patient portal. You can enter all of the information, or you can do it all written and send it off. And then within 3 to 5 days, you get the information back. And you get a plethora of information. It is amazing. You get an integrated report of gene-drug interactions, drug-drug interactions, testing of 127 medications from 26 drug classes, 15 genes that are supported by data from randomized controlled trial. I don't know about all of you. I practice evidence-based medicine. Between medical school and residency, it was truly beaten into me the importance of well-researched studies. And so when I looked for the gene tests that I was going to work with, it was important to me that the clinical studies behind IDgenetix were very solid. And so IDgenetix is supported by a large multi-center randomized controlled clinical study of patients with depression and anxiety, which has been peer-reviewed and published in the Journal of Psychiatric Research. So I feel very comfortable with the research and the studies that support IDgenetix. If you look in front of you, you have a sample report that is for our case study. And you can see it's very simple. We have as directed medications and use with caution. Use increased monitoring. The report provides some personalized medication summary, and it really guides therapy. It's very easy to read. It's got medications that are currently being taken, which is something that you provide when you give the information, but then it also lists medications that are suggested, genotype and phenotype, as well as predicted drug medication phenotypes and clinically significant information. So let's go back to our current case study. We found that the COMT enzyme was activated. This enzyme is responsible for the breakdown of dopamine in the frontal cortex of the brain. And when it's activated, then it breaks down dopamine too quickly. So we found Wellbutrin was a good option. We added Wellbutrin. The other thing that we find is TMS is a very good option for people with this activated enzyme. So we started TMS on this patient as well. TMS is transcranial magnetic stimulation. It has been approved by the FDA for anybody who's failed one antidepressant, and patient did extremely well. The other thing we found was an SLC6A4 alteration. This is a synaptic transporter for the protein for serotonin reuptake. What we find when we see alterations with a long-short genotype is that SSRIs act differently. There's greater risk of side effects and less efficacy. If you remember with this patient, she had taken 3 SSRIs, and with all of them, she had had side effects. We also found that with 3 CY450 enzymes, she had some major problems, and those liver enzymes, she had ultra rapid metabolism, and therefore we had to make some adjustments in her medications. And the best medication was desvenlafaxine or Pristiq. And so we went ahead and we started her on desvenlafaxine as well. Mental health has truly entered a new era. Patients are expecting personalized care. The only way that we can actually do that is by using a test like IDgenetix. You know, I look at oncologists, and I think, you know, they would never prescribe a medication for breast cancer for HER2 without doing a genetic test. And now I feel like I don't think I would ever prescribe a mental health medication without actually doing an IDgenetix test. This slide is a great slide. It really shows all of the things that IDgenetix does for us. It eliminates that trial and error prescribing that we have been doing all these years that is not really serving our patients well anymore. It gives us that drug-gene interaction, those drug-drug interactions, some of those lifestyle factors that really are affecting metabolism. It's incredibly easy to use. One of the things that I didn't show you is it impacts response and remission incredibly, which is amazing. Something that Ross can speak to more is how exceptionally accessible it is. Medicare, Medicaid, TRICARE, it's all zero out of pocket. This is a very expensive test, but for people who have commercial insurance, it's only $330. And for my patients, they find that it is very much worth it. I know we always like to hear follow-up. We always like to hear, how do people do, right? My patient now denies any feelings of depression or anhedonia. She describes herself as highly motivated and productive. feels like a new person. When asking her significant other, he feels that she is better than she has ever been. And her PHQ-9 is now 0. And that patient is me. So when I speak to the IDgenetix, I really speak from the heart, because it has not only changed the way I practice medicine, but it has truly changed my life. So I hope that you will see the way that it can truly change the way that you practice medicine. And I hope that you will consider it, because medicine is changing and patients are expecting more from us. And I think we need to change the way that medicine is being delivered. And the only way that we can do that is by changing it individually, one by one, ourselves. So thank you. I'm happy to answer any questions that you might have.